Good morning. We will start today's ECG conference. This is the ECG we will be talking about today. Dr. 조석철, do you have any comments?
Vision is about the first is considering the two days. It was this negative and 31 and APL plastic, so here and that this program is permanently negative. So it will be one more big first in the big safety and secondly virtual grade PV makes HSS and with yeah. One word second. Sorry, this and this. empty. Spreading to there is a very foundation.
Dr. Sorosaya, Dr. Pagmantulam, Dr. Kyo, do you have any other comments?
Heart rate is increasing, approximately 180 BPM, AV dissociation, LBB tension, and same pacing spike, sutural action, monographic.
So what did you see in the dissociation? After Joe also mentioned about the dissociation and retrograde P, where did you see? After Joe first?
We are trying to see the retrograde PV.
You mentioned.
I think in before P5 in QA looks like probably will shape.
마우스를 좀 찍어줄래요?
Yeah. Okay.
Center PA dissociation?
Uh,
Retrograde P?
yeah, I think.
So Dr. Pagmantulam, where did you see PA dissociation? You mentioned.
Usually after
Which read?
B2, B1 and 2.
B1, 2. Where?
Also ABR.
ABR.
Yeah.
Where? Okay. Only the people who has clean mind can see that.
Yeah.
Okay, 진행하시죠.
this case was a female, 54-year-old patient.
Okay,
He
hey,
had
go back to the EKG, guys. Can you guys hear me? Go back to EKG.
이건 넘어가지 말래. 황 선생님이신 것 같아. 근데 소리가 안
볼륨을
들리는데?
좀 키울 수 있나?
마이크 소리가 안
Can you hear me?
들리는데?
Can you hear me now?
소리가 안 들립니다, 지금.
소리 들리세요? 안 들리세요? 들려요? 소리 안
들려요.
들려?
네,
어.
들립니다.
오케이, 들린다. 어떻게 닥터바가 안 들려?
아니,
들려요?
잘 들려요. 예.
오케이.
이쪽 스피커인데. 안녕하세요, 선생님.
Yeah. So, AVR, you see pacing spike and wide current complex. So clearly the pacemaker rhythm, probably upper rate behavior because of the rate. But if you look at the V2, there's something change in the S segment throughout the tracing, also pre-QRS complex, just before the pacing. So you got to open differential diagnosis. One could be pacemaker can have an upper rate because of your sensing atrial activity maximum or faster than maximum, or your sensing retrograde P, we call so-called PMT. But modern pacemakers, as you know, they already have most of them PMT algorithm written. So seldom sustain more than 10 bit. They will self-terminate because they have an automatic configuration into the pacemaker system. So you wonder, you have to discuss whether this is an atrial flutter or atrial tachycardia sensed by the pacemaker 2-to-1 or maybe even faster than that. So that's going to be the differential diagnosis. Now, what do you think about this pacing complex? Is it appropriate for the dual chamber pacemaker? I think that's the most important thing here. Where this pacemaker lead is it RV or LV? First thing. It's an RV, right? It's a lap bundle. Agree. But then pacemaker has extreme superior axis, almost like posterior, septum, or maybe posterior apical, something like that.
Yeah.
So this is not a good place to put a pacemaker, right? You wanted to have a dual chamber pacemaker implanted more septally, so you can make a more natural lap bundle pattern or relatively narrower QRS complex. So those things that you need to look for when you're looking at the pacemaker rhythm, okay?
So we can exclude the potential BT because we see the small bleed in front of every
Right.
single QRS, the wide QRS complex. So it is pacemaker related rhythm, but we need to differentiate this pacemaker induced tachycardia or atrial arrhythmia related tachycardia. So we have to vote.
Yeah.
You have to vote.
Chairman is eating. I'm sorry. Disturb your breakfast.
No, why not? Yeah, let's vote from this point.
So PMT,
Raise your hand.
1, 2, 3, 4, 5. 오케이. 6명. 그다음에 atrial arrhythmia, atrial fibrillation. 하나, 둘, 셋, 넷, 다섯. one people difference. 6-5.
Yeah,
PMT
and
1.
Mostly YB versus OB. Yeah, pattern.
Dr. Wang, you have a cast vote.
What is the notching in B5 and the almost very peak of your QRS complex downstream, R, not the, coming down, follow the QRS. Yeah, there's notching. Is that notching at the downstroke in S wave, deep S wave? And then if you look carefully, that notching keep changing. You see it? Next one, different. Next one, the next one.
Yeah, Dr. Joe already mentioned it, that he has a eagle's eye.
So what's the reason that the T QRS complex change in morphology, pacemaker rhythm, especially a pacing from same site, I assume? You gotta have something else going on in there. Otherwise, your R wave cannot change because this is the absolute refractory period. For you to have a PMT, if assuming that that's retrograde P, that's too early. You can sense that P from the pacemaker physiologically. Make sense? So you have a once pace ventricle that has a ventricular refractory period programmed by pacemaker. So pacemaker is blind, it can't see anything. What happened? Assuming that is a correct, that's a real thing. It is favor for the supraventricular tachycardia, atrial flutter or something going on, and pacemaker behaving upper rate. That would be argument here. Okay? Any other question, comment?
What do you think the lead V2 in the S
V2 is
segment?
the same thing. Yeah,
There is
it's the same
some
thing.
undulation and
Right,
difference in every single beat.
that's correct. So I think a precordial lead is much more evident that this is probably supraventricular tachycardia or some atrial tachycardia flutter sensed by the pacemaker upper rate behavior. I think that's what's going on.
So now 6 to 6. Can we see the answer?
Okay, let's take a look.
Was a 54-year-old female. She had palpitation, dizziness, and pre-syncope symptoms from a month ago. Her past history was that she had hypertension and she was on hemodialysis due to ESRD, and she was bedridden, paraplegic woman due to spine fracture. She had paroxysmal AFib, which has a score of 1, and she had typical A flutter and 6 silent syndrome, tachycardia syndrome. And she had a pacemaker insertion done on April 9th, 2025. So this EKG was after the pacemaker insertion.
After.
Yes.
Immediate after.
2 days after.
2 days after. Okay.
This was
So
her.
why are you saying that the patient had a cardiovascular score 1? I'm not understanding that. Why the cardiovascular 1? Patient has hypertension. She got a renal failure, 54 years old. Is this really cardiovascular 1?
Cardiovascular. ESC guys
Okay.
recommended to exclude of
All
the female sex.
Okay. All right. So you got after the just a chest X-ray.
Yes, this is her chest
Okay.
X-ray.
Okay. So
And these were the tests done outside of the hospital before coming to Severance. Her echocardiography showed that she had normal size LV and ejection fraction of 72%. Her diastolic function, E over E prime, was 13.3, and she showed no abnormal wall motion. And she had mild MR, trivial AR, and no pericardial effusion. Her coronary angio done outside was also normal, and the Holter test showed that she predominantly had normal sinus rhythm and paroxysmal AFib burden of 6.1% and 4.13 second pause after AFib termination.
okay.
So this was her initial electrocardiogram on the day of admission.
Okay. What do you see?
That's right. Then, so after the first EKG in the morning, this was taken in the morning, and this was after the ablation on the same day.
Oh. Wow.
So they did ablation same day.
Yes.
And retrospectively, let's discuss one thing. Is the patient really needed the pacemaker?
I'm very skeptical to implant pacemaker in this patient. Does she has a history of syncope?
She had pre-syncope symptoms, but I believe
Oh,
that,
hang on a second there. She already paraplegic,
yes,
right? So
yes.
how do you exclude the possibility of autonomic dysfunction from the paraplegia causing syncopal episode? So this is going to be a little bit of a clinical thinking to do. I am not criticizing whatever did, but when you see potentially more than one episode or complexity of a syncopal episode, let's assume patient is pre-syncopal, but the patient is paraplegic, and then she has already severe neurologic dysfunction. So I assume she's wheelchair dependent, correct or not? How she been mobile? By ambulatory? I doubt it. Paraplegia. So then indication for pacemaker is for what? Because the patient was a little dizzy or near syncopal? We need to be a little bit more thoughtful on those diagnoses. Okay? Because you have a 4.7-second pause, whatever it might be. Somebody has a normal cardiac function, all that, 54 years old. Indication of pacemaker should be evaluated very, very carefully, especially when you have a neurologic condition associated with the case. I'm just raising this point for the clinical thinking for you guys to learn, okay? I'm not criticizing. Okay, so basically patient has or what? EKG sinus rhythm, left atrial enlargement, severe repolarization abnormality. From what? Why do you see this waterfall T wave? This is what? Could it be possibly pacemaker memory and left ventricular hypertrophy? Or this is a truly some bad thing going on? What do you think? But you had the coronary angiography, all that stuff already, right? So what happened if you do stop ventricular pacing and then do sinus rhythm ECG right away? Probably this is a cardiac memory from the pacemaker, what reproduction abnormality. The patient clearly has a LVH, left atrial enlargement. Okay? Anything else?
So what do you think the reason for the T-wave inversion in this situation?
You asking me or asking everybody?
No. I'm asking Dr. Kim.
Okay.
Is this after rapid V pacing?
This was,
Did you see the
actually, I did not see the patient, so I am not 100% sure of the situation.
So I'm asking how differs the sinus rhythm ECG before pacemaker implantation? Before. No ECG?
There's no ECG before that.
No.
Well, it's a supraventricular tachycardia. There you go. Your tachycardia, basically T wave is a concordant with the R wave. Now suddenly your T wave is a inverse axis, 2-3 AVF and the lateral precordial leads. So normal ECG, your R wave goes with a T, or T wave was R, either way. But this is a clearly, but what is a particular attention that you need to pay attention is that how that looks this T wave. That doesn't look like a waterfall T wave. They're symmetrically deep. Can you see that? Especially V4, V5, V6. Is this a normal T wave?
Absolutely no.
How the T wave? Yeah. How a T wave should look, guys? Normally,
looks
first
like
first.
Yeah, coronary T-wave inversion, but the coronary angiogram was normal. So something happened in this patient. If the baseline, the ECG before pacemaker implantation.
Right.
So that's why I'm asking how's the T-wave before pacemaker implantation. If it happens after rapid beat pacing, it may be related to pacemaker, rapid beat pacing related memory effect. But we need to exclude the potential stress-induced cardiomyopathy because lateral precordial lead shows deep T-wave inversion.
Sorry, actually, this is the EKG before the pacemaker because the pacemaker was done on the 9th. So I believe this is the first EKG prior to the pacemaker implantation.
So how do you interpret this ECG? What's the rhythm? This is not a sinus tachycardia. I hope you're not thinking this is a sinus.
Atrial
Is
flutter.
it sinus tachycardia? Yes, most likely atrial flutter 2 to 1. So when they implanted the pacemaker, probably patient had a flutter and it tracked the to, operate the pacemaker behavior. I think that may be favor for that. Now, we still need to explain why the T-wave inversion. So when do you see symmetric T-wave, guys? Most commonly in your practice? Ischemia, but you ruled it out already, right? So why the T-wave inversion happen in ischemic event? Because your myocardial infarction is what? Endocardial, right? Typically subendocardial. Then your epicardium is kind of somewhat saved or paved. That's typically called a symmetrical waterfall T wave or cerebral T wave. But unlike a cerebral T wave, because the patient heart rate is normal, typically you would have a bradycardia. So this is a cardiac memory, most likely. Okay. So remember that symmetric T waves, they're pathologically abnormal, but can happen after the ablation of the WW posterior septal pathway or after ventricular pacing. So you have a two type of cardiac memory, pace-induced and also abnormal ventricular activation by axillary pathway, especially posterior septal pathways. Okay.
Next ECG was taken approximately 2 weeks after when she came for her outpatient follow-up.
It's getting better.
Yeah.
Okay? This is a cardiac memory most likely. That usually goes away 3 to 4 weeks. And if you want to speed up the resolution of this, sometimes AC inhibitor can help you. Okay.
So her final diagnosis was that she had paroxysmal AFib, counterclockwise, CTI-dependent A buffer, and the RFC was done. She still has her pacemaker insertion, and for the medication, we increased the dose for the propafenone and the bisoprolol, and the apixaban was discontinued at the outpatient.
Okay. Now, may I ask why somebody put a pacemaker would be in the right side subclavian vein? Because the dialysis catheter was in the left? Do you know that?
Might be.
Might be.
Yeah, she had
Fistula on the right arm.
AVF in the left arm.
Okay.
For
All
your
right.
information, generally the ion channel remodeling recovers within 3 weeks after converting to sinus rhythm, and tachycardiomyopathy generally recover within 48 hours. So you can follow the echo or ECG, considering those periods. Okay, Dr. Wang, so we have 5 more minutes before international conference.
Okay. So this pacemaker lead placement, as we suspected, is in the posterior toward the apex. That's why EKG looks lap bundle without transition and the superior axis. And typically, you don't want to put a pacemaker lead in that area because your contraction LVG synchrony is much severe compared to when you put it in the subclavian area. So certainly right arm placement, that can be challenging, but sometimes I think actually if you manipulate your stylet carefully, you can do better job. So for you to think about it next time implant a pacemaker, try to avoid inflow RV if you can. Other than that, I think really not much show here. Chest X-rays, typical left ventricle hypertrophic pattern. Nothing else I see. Now, you guys use a right side implant, shorter lead or same size lead? Have you thought about that? Pacemaker.
What was your question? That one?
My question is, do you use a shorter pacemaker lead length from the right implant versus the left side? Because the right side pacemaker length requires it shorter than the left side implant. Therefore, your pocket gonna become very bulky if you use the same size lead. So you need to use a shorter lead to avoid the pacemaker pocket bulkiness. Especially Korean people, very skinny, they tend to have a pacemaker pocket sticks out. That actually also causes a lot of discomfort and premature pacemaker pocket erosion. So think about that when you do next time.
짧은 게 나와요? 리드가?
Yes, there is available. Or you can put a 2 HL lead, 46. There's a 42 also available. Okay. Key is that to try to reduce the pacemaker pocket volume to the patient. That is a key of a comfort first thing you need to do. Obviously, surgical technique and so on, but it is important to think about those things. Okay.
Okay, there are no any other comment or question. We will close this session and move to next international conference. Thank you.
Thank you. Thank you, guys. Good case.
옵션 없지 않나요? 우리나라 짧은 리드 안 나오는 거 그런 거 아니에요?
좋아요, 있잖아.
좋아요.
모르겠어. 52를 다 하고 싶더라.
네.